everyone, and welcome to our December Public Health Preparedness webinar. I just wanted to go over a couple quick announcements and dates before I introduce our speaker for tonight. Let me just share my screen. All right. Okay, so as I said, welcome to our December webinar. And we've got a number of upcoming dates that we are looking forward to seeing you. We've got tonight, obviously, is going to be our December PHP webinar. Next week is going to be our IAEM meeting, our monthly meeting. So we're going to be having a speaker then. Because of winter break, we will not be doing a webinar in January. So the next date on the agenda is going to be our IAEM meeting in January. These are the second Tuesday. Our public health preparedness webinars are always going to be the first Wednesday. I'm going to skip this one for a second, and then our first PHP webinar of the new year is going to be in February, and that's when we're going to have somebody speaking on weapons of mass destruction coming from the National Defense University. And then February the 11th, we have an IAEM meeting. And if you're interested in being on the IAEM distro list, please shoot me an email. My email's here on the slide, and we can add you. We send out calendar invites for them, and we've got our student chapter is just getting kicked off, so we're looking for anyone who is interested and wants to help shape it, and anyone who's looking to get their emergency management certifications. We've got a great core group of people that are really excited, so please get in touch with me if this is something that you would like to participate in. So going back to this date in January, we as in Penn State are working on a rural health preparedness in rural communities virtual mini symposium. Here is a screenshot from the website, which I have the link to on the next page. But preparedness in rural communities is a very important topic, not just to Penn State, but at the local, state, and federal level. So we are hosting a virtual 2-day mini symposium to identify opportunities in public health and agricultural preparedness and response in rural communities. We are gonna, it's a 2-day mini symposium. It's gonna be a Thursday and a Friday from 11 to 2 each day. And Thursday, we're gonna take more of a national approach, and we've got speakers coming from the Department of Homeland Security, Department of Agriculture, Department of Health and Human Services, and they're going to look at rural preparedness from a federal level. And then on Friday, we are going to zoom in a little bit, and we are going to be looking at it from a state and local perspective. So this is something that we are really excited about, and this hopefully you've seen this website before and you've heard about this before, because we've been sending it out on our distros and our LinkedIn pages and everything like that. But if you haven't, again, please shoot me an email. I can send you the website. It's got information about the symposium. It also has the registration information. There's a $25 fee for everybody who is not a Penn State student or a student of Immaculata College. Is that right, Jean? Okay. So you can register on there. There's a student registration. There's a everybody else registration. So we are going to be putting more information up as far as a specific agenda, but you can go there now. You can see the overview. You can register. You can see who our planning committee is, and any information is going to be on that website. And again, if you've got any questions, you can send me an email, and I will definitely answer them for you. Spring registration is open. We've got a number of classes that we are going to be offering. Sorry, we are not doing 810 this spring, so that was a typo on my part. But we've got 510, 594, and 596, and also 830. So if you have not registered yet, please make sure that you get your registration in, and we would love to see you in class in the spring. And as always, if you've got any general questions about our program, obviously you can always come to one of your professors, you can come to one of us, or you've got, this is a general distro for our program, so you can send any questions there and we will get back to you. Now, I am going to stop sharing because the reason that we are here tonight is not to hear from me. It is to hear from Keith McMinn from Lifeline. And Keith, thank you so much for joining us tonight, and I will turn it over to you.
Well, thank you, Jennifer. I would like to share my screen, and it says I need to send a request to do that. So I will do that. Does somebody have to give me permission to share?
Chulapal, did you?
Nope, I don't have to.
Good.
You can share it.
Okay. Okay, now it came up. All right. Can you see it?
Yep, we can see it.
All right. Thank you again for having me tonight to speak to you about medical transportation and its impact on health systems. My name's Keith McMinn. I'm the director of Lifeline Services at Penn State Health. Have been with the organization now for about 3.5 years. Prior to coming to Penn State Health, I had a 25-year career in Maryland. I'm actually a retired Maryland State Trooper, and my final 4 years in Maryland, I was the commander of the aviation unit. For those of you who know anything about the medical transportation system in Maryland, the state police receives funding from the Maryland legislature to provide air ambulance services in Maryland. It's a unique model, and I spent most of my career there. Originally from Lancaster, Pennsylvania, and happy to be back in central Pennsylvania when I moved back 3.5 years ago. So we are going to talk about several different areas of medical transportation. I'm first going to provide an overview of Penn State Health Lifeline services. You know, we're not really unique. Health systems across the U.S. have transportation challenges that impact the cost of care, impact their length of stay, which is a key metric for any health system. So their transportation services have to align with their system goals like ours do. They have to have an EMS strategy, which we'll share with you as part of this presentation. Health systems often have medical transportation performance metrics. I'll share with you what they are here at Penn State Health. Again, not unique to Penn State, but there has to be performance criteria, key performance indicators on, how well we are moving patients and how well we are impacting throughput for health systems. Transportation services is a logistical challenge for any health system, and it's a costly measure to maintain the equipment and, of course, the staff. So we really have to make sure we're on our game when it comes to providing appropriate clinical care and doing that in a timely manner. There is a nationwide EMS crisis going on. You see it on the news on a regular basis. The root cause of that crisis is a revenue cycle related to EMS. At some point tonight, I'll play a short trailer, a 2-minute trailer to a documentary about the EMS crisis that's been circulating around the US. It's been in movie theaters. It's oftentimes sponsored by large health systems to gain awareness of our legislators and other key stakeholders that the system is not sustainable as it currently is. We'll talk about the evolution of non-medical transportation services. Those health systems that have traditionally provided medical transportation have had to start to think outside the box and provide non-medical transportation services that are unfortunately oftentimes not reimbursed by payers. So they have to figure how they're going to have to fund that. Then we're gonna finish the night by talking about two specific programs that we have here at Penn State Health that are under trial. One is called our Redirect program, and the other is an alternative to transport treatment in place where we use our virtual health partners and attempt to keep low acuity patients out of the hospital to prevent the overcrowding and things of that nature. So that's where we're going to go tonight over the next hour. I assure you it's not death by PowerPoint. There's only 14 slides. And I'm looking forward to this. So thank you very much. So Penn State Health Lifeline, 38 years of providing this service. Of course, we are we're located with the College of Medicine and Hershey Medical Center in Hershey, Pennsylvania. We are a hospital-based ground EMS service. We provide 911 service for 56 municipalities across 6 counties in Pennsylvania. We also have a critical care transport program, both air and ground. The air component is that mission is accomplished through helicopters. Penn State has made a significant investment in that program over the years, and it really is a model in the country. So much that I was just appointed last week to a CMS air ambulance quality and safety committee that's going to write standards for air ambulance transport in the future. And, the program really deserves a recognition for that, being around so long and really being well known, providing quality critical care transport. We have about 450 employees in the entire department. The operating budget is about 45 million. We'll talk a little bit later on the direct unfavorable margin. As I said, providing transportation services is a costly venue. Every year the budget comes back unfavorably. The reality is the reimbursements for service from both government and private payers do not make up what the reality of what the cost to provide the service is. So the question would then bear, why would you provide a service that has an unfavorable margin? We obviously make up for that unfavorable margin by bringing patients into our health system, caring for them either in our community hospital or at our flagship hospital at Hershey. Directing patients into our health system is how that margin is made up. But most transportation systems in the U.S. attached to a health system, especially an academic health system, are going to have a direct unfavorable margin. And in our service, we do about 6,200 requests for service annually. Those requests come in all shapes and sizes. That includes the 911 service, includes the critical care transport program, and that includes all the non-emergency transports, meaning patients being discharged from the hospital that need to get home or get to a rehab facility. All those things impact length of stay, cost of care, and we'll go over that over the next couple slides. So aligning with system goals is key for any department, especially the Lifeline department. And if you look here at this list, these are the organizational goals for Penn State Health in FY25, all of which my department align with in some fashion. We strive to provide the same quality of care and the same patient safety guidelines as if a patient was in our hospital. We consider the program to be an extension of the hospital. If we are going to retrieve a patient at a small community hospital and bringing them to our flagship hospital in Hershey at the Hershey Medical Center, we do so as in when we arrive at the bedside, we're an extension of the care that's going to be provided at the Hershey Medical Center. When you think of patient experience, very important measure for any health system that's now recorded under CMS guidelines. Oftentimes, a Lifeline EMS crew or a Lifeline helicopter crew may be the first encounter that a patient would have with our health system. So when we talk about the mission of Penn State Health being the most trusted brand of healthcare in central Pennsylvania, our employees are at the front line. It's often the first individuals in the health system, the first clinicians that a patient will encounter. And as you can imagine, first impressions are everything. So we don't underestimate the impact we have on patient experience. Employee engagement, very important in any health system. Engaged employees are known to be more productive and provide better patient care and safer patient care. Obviously, we have an academic mission. My counterpart, we operate in a dyad model. So the clinical care that the EMTs, paramedics, and nurses provide in the field are overseen by a physician that have appointments under the College of Medicine, that are medical directors of the various programs that Lifeline runs. And then the operations goal for FY25 is reducing the length of stay, and that we have a direct impact on that by providing timely transport when a patient needs to be moved. Oh, gotta go back. So let's talk a little bit about, I use this map to talk about the EMS strategy for Penn State Health. Being that an EMS program is costly, the strategy is actually a fairly simple one. We provide EMS service in the communities that are in the footprint of Penn State Health hospitals and clinics. And we generally are not interested in providing that service in areas where we don't have hospitals and clinics. Kind of a simple strategy. You know, again, if you think of us being an extension of the hospital, it benefits us to be the first person caring for that individual. Lifeline ambulances, Lifeline helicopters are big marketing tools in the community. Big shiny moving billboards, I guess you would say. So, you know, those areas in blue are all the areas. Those are the 56 municipalities that we provide service to. The yellow stars are where we have Penn State hospitals. Keep in mind that 10 years ago, it was a single hospital in Hershey. We're now a 5 hospital system that operates off of a hub and spoke model. And, you know, many of our hospitals, obviously, and other health systems in the area refer tertiary and quaternary patients to the Hershey Medical Center. And if they're very sick, they use our services to get them there. So that's the EMS strategy. And the critical care transport strategy. So we really provide statewide service, but our primary service areas are shaded in the blue and the pink and the yellow in that area. They may be scene flights to go out and retrieve a patient at an accident scene and bring them to our trauma center. We're the only pediatric trauma center in central Pennsylvania. It could be somebody having a STEMI or a stroke that needs to get to the closest appropriate center. But those shaded areas are also generally where the referral patterns for transfers into Hershey Medical Center come from. and the timeliness of those transports benefit patient outcomes. We know that the sooner the patients get to the, to the higher level of care, we know they do better. But we also know that from a marketing strategy and keeping market share, that if we have resources available in these areas, patients are then more likely to come to Penn State Health. So that's how that strategy rolls out. Well, when we talk about the role of medical transportation within the health system, it really is part of community health. It's being in the right place at the right time, okay? And has already been mentioned, we're an extension of our hospitals and clinics focused on quality and safety. The investment that we've made in our equipment, we really can provide the same level of care in the field as they can get in the hospital. Very important. Penn State having a children's hospital in Hershey, over half of our critical care transports are to support the children's hospital, bringing the tiniest babies or bringing sick kids to our children's hospital. Very important focus of our mission in Hershey. Another primary role of medical transportation for any health system is throughput. Okay. And it is a complete domino effect. Okay. Patients are discharged from the hospital daily that need that can't, their family may not be able to take them home for whatever reason. Maybe they're going to a rehab facility for a period of time. They have medical needs. So when the physician makes the decision to discharge that patient and decides on the level of transport that's needed, us getting bedside in a timely manner opens that bed up. Because if you think of the domino effect in the emergency department, we've all heard of overcrowding, very busy emergency departments. There are oftentimes patients boarded in the emergency department waiting for a bed up in our hospital. So by us providing organized, timely transport, opening a bed, getting the bed cleaned, now somebody in the emergency department, maybe your family member, then can be admitted to the hospital who has been waiting in a hallway in the emergency department. When that boarded patient in the emergency department now has a room upstairs, a person in the waiting room, right, can then be seen by the next physician. And nobody likes to wait for long periods of time in our emergency department. The reality is sometimes they have to. So it absolutely has a domino effect on throughput, cost of care, availability of beds. It's not the only, transportation is not the only thing that has a say and some input in that area. We'll talk about other things in a little bit, but it's an important component. Already mentioned decreased ED overcrowding and boarding. We have a whole slide coming up on length of stay, and already mentioned that, we do, one of the roles of medical transportation is using our moving billboard as marketing for our health system. So next slide, very busy. Let's talk about length of stay. Very complicated issue. It is one of the biggest challenges for any health system. And the graph on the top shows a rolling 12 months of length of stay for the Hershey Medical Center. Anything in the orange is considered excess length of stay, meaning it's an area that Hershey Medical Center needs to improve on to cut down. These are individuals that have stayed beyond the CMS guidelines in the hospital for various reasons. Not all transportation related. We'll talk about transportation in a minute. The red line is where Medicare wants us to be. So you can see there's a lot of area of improvement there. I'll tell you in a minute how that converts to dollars. Okay, and we work closely with care management, which is the team of nurses and physicians at Penn State Health that monitor all this, and they are really coordinating the care for the patient, especially when they're discharged and what follow-up care they're going to get when they go home. But obviously there's some improvement to do there. Everything again, so there's some other parameters I want to put around this scale. This scale is from ages 18 to 45. It's middle-aged individuals. Anything over age 45 under Medicare, when you talk about length of stay guidelines, there are generally other factors beyond the hospital's control that impact length of stay. So we don't get penalized for that. But just important to differentiate. The area that transportation affects the most, if you go to the graph on the bottom with the green line, the green bar, these are patients who stayed additional hours in the hospital. Okay, they probably weren't discharged when they could have been for a number of logistical reasons. It could have been that their caregivers weren't ready to accept them at home yet. It could have been that we had delayed transportation. It also could have been that the doctors had not necessarily coordinated their discharge plans appropriately. It could have been that they were waiting for an insurance authorization or something of that nature. Oftentimes, timely transport impacts that green line. The care coordination team will call my team and want a discharge in the morning, but the reality is there are oftentimes more transports than what there are ambulances to do those transports. So the patient who they want discharged at 9 a.m. may not get moved by 5 p.m. that day. So they've spent some extra time in the hospital. So some key numbers for you to understand: an extra night stay in the hospital is $5,500 of unreimbursed care for Hershey Medical Center. Okay, and if we move back up to the orange area, that orange area costs our health system about $170 million in unreimbursed care. That's the estimate. There are people that much smarter than me that put this information together, but we often talk about it in our length of stay committee meetings. So getting back to what we're talking about tonight is transport. Transport, some health systems have already studied this, very scholarly, and done a lot of research, and as high as 20% of the unnecessary stays and the unreimbursed care can be related to delayed transport. We are just starting this work here at Penn State Health. I don't have a measure for it yet. I don't know what it is here yet, but it's interesting work that we're just starting on. We have an IRB that's going to be, submitted for it and all that, but we know from other research that up to 20% of unreimbursed care or increased length of stay can be caused by delay of medical transport. So performance indicators or performance metrics that we often use for transport at Penn State Health are generally defined by maintaining an 85% or above average defined as arriving within 1 hour of the request. So when we receive a request to move a patient, we want to be bedside within an hour, 85% of the time. The red line represents the goal, and these are different levels of transports here, BLS, ALS. That's the level of care that the physician has said needs provided during the transport. We've done pretty well here at Penn State Health. This 85% or above is a very common performance metric in private ambulance service contracts. So some health systems don't have their own EMS system. They contract that to nationwide for-profit companies like AMR or a company called Ambulance. You probably have heard of them, or GMR. And these are very common performance metrics that are often built into those contracts that we use at Hershey Medical Center to drive what our performance is. I will tell you, during COVID, these metrics were very skewed, and we had a hard time meeting these metrics. And I'm not sure if any of you are aware, but during COVID, the federal government deployed EMS or ambulance task forces to Hershey and to other places across the U.S. to help move COVID patients. That's the first time that had been done in our area and was very helpful to support throughput. All right, let's talk a little bit about the EMS crisis. Again, I'm going to play a trailer if you can bear with me here just for a minute. Let me bring this up. So this is, again, a 2-minute trailer. There is a 1-hour documentary that's been in movie theaters, all that. It really provides a good summary of why we are where we are. And I found this to just explain it very well. And you guys can still see the screen, correct?
Yes, we can see it. Is there audio with this?
In spring of 2020,
Oh,
and
there we
we
go.
were pretty hard hit. It was kind of like a 9/11 every day. So bleak during that time, seeing the cries and screams of people, seeing the disparity that I'm the one working on the road, and taking people to the hospital. That means the last time interacted with that family member, their loved one, it got to a point where it broke.
You can freak out. It's in the ambulance, and then when we're inside, then we're like calm and collected because we have to reassure them that we are there to help them, and then that we know what we're doing. And even if like inside we're like, oh my god.
Pandemic hit. Many people.
Uh-oh.
Oh, that wasn't an opportunity that 911 EMS was afforded. They're the third uniform service. Their job is as dangerous as police and fire. They have been right up in the front lines, taking care of very sick COVID patients constantly.
Sorry about that. I'm getting some signals here that my internet here at home is a little bit unstable.
Another thing we can do, we can give it a chance to come back up, but you can also post the link for it in the chat, and then that way, if people want to pull it up.
I'm happy to do that. I might have to do that. Figures I really didn't have any problem all day, and then
That's always the way it works.
Infectious disease.
We've met people who've been in it for a lifetime, and they've never seen it more sort of broken than it is now.
Many people assume incorrectly that EMS is considered this quote unquote essential service. And unfortunately, in many of the legislative frameworks, EMS was just left out.
One of the biggest challenges with EMS, the way that it is structured today, is the funding mechanism, the economic model. All across this country, EMS agencies can't recruit, retain, and staff ambulances to a point to ensure the public safety.
One of the biggest disservices that I believe as a very high productive and financially sound country is when we can't take care of our own.
I believe our rural areas are the alarm sounding. We want people to know that this is a crisis that they need to pay attention to.
Particularly rural areas don't have the required EMS coverage. When someone calls 911, there's no assurance that they can get an ambulance.
People always want to talk about the cost of responding to the call, whereas we should be talking about the cost of readiness to respond to the call.
We need to have full-time paid personnel at adequate salaries who have chosen this as a profession. This is a noble profession.
As an EMS worker, it's very difficult to live off of one salary. Therefore, I have to work at several different agencies just to pay my bills.
EMS has not been considered and viewed as a required essential services for the what ifs. And is that, as a society, something that we are willing to fund and pay for? That's where it starts.
Doing with essential services is saying that this is a critical piece of public safety, much like fire and police, and that we want a bill to be able to make sure that this essential service gets funded appropriately and it can deliver the service that the public expects.
It doesn't translate into money per se under state law to simply call something an essential service. We have to rebuild the EMS system from the ground up to create a system that has enough money to sustain itself.
All right, let me get back to my presentation here. So they talked a lot about the funding there, or in the middle of that video, they talked about the funding. The reality of the funding is this. So to staff a 24/7 ambulance, one 24/7 ambulance in a community with the necessary equipment, that includes the ambulance, that includes a heart monitor and all the things that go into an ambulance. It's $1.2 million to do that. That's generally what it costs. 65% of the patients that an EMS service encounter are going to be part of government insurance, either Medicare or Medicaid. There hasn't been an adjustment to the Medicare rate for EMS service in greater than 20 years. The reality is that we get about $400 per transport plus some mileage. And the cost for me to provide that service is double that, $800, $900 per transport. So if you can see any business, right, where 65% of your transports, you're only getting half of what it costs to provide that service, that's at the core of the problem. So what's being done about that? Well, for those of you who are involved in EMS, you're aware that we are right now in a required data collection period It's called the CMS Ground Ambulance Assessment. We're submitting, Penn State Health just submitted their information last week for fiscal year 24. And what we believe they're going to do is turn EMS into a value-based care model, where right now we are not incentivized financially to not take patients to the hospital. In fact, some states, including Pennsylvania, have requirements that when EMS shows up, unless the patient signs a refusal, we must take them to the hospital. We believe they're taking all this information in, going to, have hearings in Washington, D.C., and then decide what should be a more appropriate reimbursement based on value-based care. That's where we're pretty certain where all of that is going, and we're interested to see what the results of that are be. So, because I mentioned that there are oftentimes not enough ambulances to go around to support the number of transports, we've had to change to looking at non-medical transportation services. On the left of your screen is we have several vehicles like this that are essentially run by just drivers that do not have medical training, and they are hired to transport behavioral health patients that don't require an ambulance from our Penn State hospitals to where they're going to get longer term psychiatric care. We had up until 2 years ago been just using ambulances to perform that work, but we're no longer doing that. We're using non-medical transports, but currently there's no way to get reimbursed for this. This is an unreimbursed expense. We've had to do that to accommodate all the other things that we've talked about. But you've also seen the emergence of things like Uber Health, Lyft, and other programs have aligned with some of your pharmacies, programs like CVS Health to, to provide transportation similar to a taxi service. And those are often programs that are not reimbursed. Health systems have budgeted funds for these services to keep the population healthy, to get patients to their medical appointments, because the reality is the cost of providing a voucher for Uber Health is a lot less than a patient missing their appointment and then not getting the primary care that they need. So you've seen these programs emerge in medical transportation systems that are all coordinated by my department. Going to talk briefly about EMS redirect. Kind of interesting. We have certainly not the first ones to look into this, but what we're doing in our health system in central Pennsylvania is trying a strategy that redirects low acuity patients to Penn State Health community hospitals during periods of high census and capacity challenges at Hershey Medical Center. So let me show you how, let me talk to you a little bit about how we operationalize this. So an ambulance somebody calls 911 to maybe the area near Harrisburg Airport, okay, which is an area that we cover. The patient wants to go to Hershey Medical Center, but we know that Hershey Medical Center has capacity and high census during that period. So if it's low acuity and a patient that doesn't need that higher level of care at Hershey, we redirect that patient maybe to our new Lancaster Medical Center, or maybe the Holy Spirit Medical Center, Hamden. It's called redirect. And what we're trying to do is improve the patient experience and avoid those long wait times that a patient that's not very sick may experience at our community hospital, or may experience at Hershey Medical Center, and try and get them the care that they need in a more timely manner. The key parameters for that program is that there are certain Department of Health guidelines that require us to take patients to the closest facility. You can imagine a trauma patient or somebody having a heart attack or a stroke. We are required, and it's the right thing to do on behalf of the patient, to take them to the closest. The patient has to be low acuity and must consent to this divert process. And there's oftentimes geographical considerations and considerations for the family when we attempt to redirect a patient to one of our community hospitals. We've been undergoing a trial for this for a year. We're redirecting about a dozen patients a month. I'm not sure that's enough to where our ED colleagues at Hershey Medical Center feel that, but we'll see how this grows and whether it's part of our care model in the future. Finally, I want to talk to you about alternative to transport and treat in place models. Just tonight, I saw something on the news where Senator Joe Manchin and Senator Susan Collins introduced legislation. So again, EMS has traditionally only gotten reimbursed for when they transport. If they treat in place, if they don't transport, they don't get any funding for that care that they provided, right? But there's recent federal legislation to change that. What we've done here at Penn State Health is we have used our virtual care platform to begin a trial where when we arrive on the scene with a low acuity patient, maybe someone that doesn't need to go to the hospital, and we convince them that they don't need to go to the hospital, that we have other ways we can manage their care. We connect them with a physician or an advanced practice provider through an iPad and maybe get their prescriptions filled and maybe treat their common cold in place, and they stay home for the night and avoid overcrowding the ED, and they have a better patient experience that way. We call it alternative to transport, and it's one of the trials we're in right now. The ambulance transport to alternative destination is not something we can do here in Pennsylvania. DOH guidelines guide that, but we think new federal legislation and legislation in the future, when they change the EMS Care Act, that will be possible. Think of that as transporting a patient to an urgent care instead of an ED, if it's something that would be appropriate for that. But currently, the guidelines in Pennsylvania don't allow that. So I've gotten through my whole presentation. A lot of different areas we've talked about. I hope you can understand how it all fits together. Again, I highlighted our program at Penn State, but all health systems face similar logistical challenges, and I'm happy to take any questions at this time.
Thank you so much for that. Sorry, I'm having trouble unmuting. That was a very, very interesting look at Lifeline, and I will let I see a couple unmuting, so I will let anyone else ask a question if they've got one to
Sure.
start off.
So Keith, this is Gene. Thank you very much for the presentation. Really opened my eyes to transport. So a couple of things. Just I'll just hone in on sort of this concept of research. So you had mentioned you were doing an IRB for an issue around medical transport. You also, as I was looking at your redirect process there too, that seems like that is something that has some research components to it as well. So you've just become a member of the PHS faculty. I'm just wondering if there's and Alexandra's here from family medicine too. So I'm just wondering if, how do you get involved with that research project?
Yeah. So my physician counterpart is Dr. Jessica Mann, and would love to sit down with you and Dr. Mann and discuss how we would do that. I agree with you, Gene, that there are three areas of potential research here. One is the area of discussing what part of length of stay can be attributed to medical transport. We don't know what that number is here at Penn State, but there's other research out there that other health systems have done that shows it's as high as 20%. But we want to know what that number is for our system, and would love that to be a project. The second area is EMS redirect. What impact does that have on throughput? You know, are we actually helping with the ED overcrowding? Are there opportunities to do more redirect? Or are we redirecting the right patients? So that would be, and then I will tell you the third area, the research is already in progress, but want to connect you to it, or anyone else that wants involved. Dr. Mann is actually leading that, and that's the alternative to care, alternative to transport. We have two third-year medical students from the College of Medicine that have already connected with us on that. But again, we're in the infant stages of that.
Yeah, well, that's great. Yeah, I'd be happy to talk to Dr. Mann as well. So, yeah, it may not be me, but I do think there are other folks around the College of Medicine that would be interested in maybe working with you. And I guess I would also just say, just your redirect project particularly seems like it's really, you know, open to operations research, geospatial mapping, and things like that in real time, not just, you know, looking back at what happened over the past month or so, but really in real time about directing that. Maybe you're already doing that, but that just seems like something that, you know, as Penn State University, there's a whole lot of people that are smart and do that sort of stuff. So those at University Park too, for example.
Those are resources I need to bring into that project. So yeah, that'd be great.
Yeah. Yeah, there's, I mean, the industrial engineering folks or health policy people, health policy administration people, industrial engineering. I mean, that's where I did operations research. That's where it seems like it could fit. Yeah, and they've got much better quantitative techniques than whatever I learned or could do now.
Yeah.
Okay, well, I'm going to stop there. I've only got a few more minutes, then I have to jump off. But if nobody else asks questions, I'll jump back in with another one.
Well, do you want to ask another one before you have to go? You're muted.
Well, then, no, I want to hear other people's questions for the next few minutes.
So Keith, I have a question that might be overall longer. So we've worked with the Cambria County EMS system and Pennsylvania Drone Association for the EMS county level response. And I know that Lifeline is consulting on the project, but how about locally Lifeline and drone involvement? Because we specifically are looking at reducing response time to overdose victims. So delivery of naloxone, Narcan through drones, which is critical in rural areas particularly.
Yeah, that's interesting. Not something we've been involved in the past. Certainly the drug overdose epidemic and all that is something we're very familiar with, but I wasn't aware of that project out there, and would be very interested in exploring.
Yeah,
that.
so that's why I did write down your email, but I'm looking. So you mentioned also one of your goals is increase NIH funding, which means we are on the same page overall.
Yeah.
And I know that SAMHSA is supposed to issue a call for proposals for EMS responses to overdose as well. So that could be nicely aligned, but we have some by now collaborations with the in the aviation sector, particularly drone sector, so it might be nicely aligned. And we do have expertise in cost benefit and evaluation, which is what you're looking at as well.
Yeah, that be interested in hearing more about that.
Question that's not necessarily related to your presentation, but more about your background. So you talked a little bit about your background at the beginning, and I was just wondering, since we have a lot of students who are either breaking into the public health emergency management field or they're trying to advance in their career, could you talk a little bit about like if you have any advice from your career that could help them as they're making these career decisions, or if there's any thoughts that you have, like any best practices that you'd like to pass on.
Yeah, so I started as a hospital-based paramedic in Lancaster and had ambitions of I heard about this Maryland EMS system, which is very well defined and has some unique aspects to it. And that's what drew me to being a Maryland State Trooper for 25 years, where I could do a little bit of both. I will advocate for the Maryland system has a lot of unique opportunities, like the air ambulance program that I was involved in, but that program and the Maryland EMS system has direct connections to Johns Hopkins, very well-known, institution that provides a lot of opportunities for research and advancement and things of that nature. And then the R. Adams Cali Shock Trauma Center, which is part of University of Maryland. That system is how I grew up. So, and then when you connect that program with University of Maryland, Baltimore County has an emergency health services degree program, which is where I got my bachelor's degree. There's a ton of opportunity down there. So not enough EMS providers formalize their education.
Okay.
Going into a degree program of either emergency management or public health or emergency health service, certainly I would advocate for that. And then, I was fortunate enough to have experience in state government and see what the government structure looks like. And now I'm having experience at an academic medical center. So that diversified experience is what I think grew me as a leader. I don't know if that helps or not.
No, it does. It does. And we actually have a lot of students who are first responders. So
Yeah.
that's really really good advice.
Yeah.
I know Gene had to drop off. He said he put in the chat, thank you. He has a meeting with his siblings about his mom. So he had to go. Are there any other questions from anybody else who is on the line? I don't see any hands or anything. Thank you so much for tonight. This was a great look at EMS. And oh, actually, before you go, I know you had it up on the screen for a little bit, but can you copy and paste the link from that video and put it in the chat?
I sure will. I'll do it right now.
Thank you. It looked really good. I want to go back and does the movie that you were talking about have the same name?
Yes. Yeah, it's called Honorable but Broken. And what I played was just the trailer to that movie.
Perfect.
So let me
Thank you. I've got to run as well.
Bye. Have a great night. Thank you for
Look
coming.
forward to talking to you about drones.
I'm already typing an email.
Okay.
Bye-bye.
Right.
Bye. And I will connect the two of you as soon as I get it.
Sure. All right. Where is the chat?
Should be on the bottom, I believe. On mine, it's on the bottom.
Huh. I'm not seeing it.
Okay, well, if you are looking for the trailer, it's called Honorable but Broken, EMS in Crisis, and you can search for it on YouTube.
It comes right up on YouTube. So yeah.
Perfect.
Hey, thanks for your time tonight. Thank you.
Thank you. Have a great evening.
Take care.
You too.
Bye-bye.
Bye.